I'd like to turn it over now to Mr. Arman Sharma, who will be moderating our HHS Leadership Fireside Chat. Mr. Sharma serves as Deputy Chief AI Officer for the U.S. Department of Health and Human Services, where he leads implementation of the HHS AI strategy.
All right. Good morning, everyone. Thank you so much to the organizers of the event for allowing me to open. Welcome to the symposium. We're going to kick off with a fireside chat with Dr. Thomas Keane. He is our Assistant Secretary for Technology Policy and the National Coordinator for Health Information Technology, and Mary Lazare, our Principal Deputy Administrator for the Administration of Community Living. Our focus at HHS, across all of our agencies, is enabling the use and adoption of artificial intelligence across the spectrum, both on the administrative back end, but also in clinical care. And one of the applications that we care about, most deeply, is that for older adults and caregivers. So in this session, we'll look at concrete initiatives like ACL's Caregiver AI Challenge, and then the broader data modernization, data liquidity work being led by the Office of the Secretary. Our main goal with this panel is for you guys to get a bigger picture of where the great work that's being done here fits within the sort of policy landscape that HHS and the administration are pushing, and how we're thinking about things, what actions are being implemented, and what measurable results that you can benchmark to. So with that, I'd like to bring Dr. Keane and Mary to the stage, and then we'll go ahead and get started. So to start, I think I'll have both of our speakers here give just maybe 4 to 5 minutes of just opening remarks about their agencies, what their priorities are, and how that might apply to you. So Tom, to start.
Great to be here. I'm actually a alum of the Johns Hopkins Medical Training Program. Not as cool as being from the business school or the undergraduate school, but I did do residency and fellowship there. And I was actually an intern back in 2003 and actually operated on patients with Marty McCary, who's now the head of the FDA. In 2003, I think, is when Arman's parents met in high school. So being on a panel with him is making me feel my age. I'm not quite 150 years old. But so the agency I work for is called the Assistant Secretary for Technology Policy. And I know that not everybody may be familiar with the structure of Health and Human Services, but Health and Human Services is a giant agency overseen by Secretary Robert F. Kennedy Jr. that has within it all kinds of different divisions and organizations. We divide them into what we call the operating divisions. That's the larger divisions like FDA and CMS that do a lot of public-facing work. And then we have what we call staff divisions, which is what I'm in, where we also do external-facing work, but we tend to be a little bit smaller. So my agency, the Assistant Secretary for Technology Policy, basically regulates electronic health records. Our remit is to regulate all of health IT, but in the world today, that means regulating electronic health records. And we have a certification program in which we make sure that the electronic health records both meet certain functionality, safety, and effectiveness requirements, and that they also interoperate, that the patient's data can be moved to where the patient needs it. Our intersection with AI and the way that HHS is thinking about AI is we want AI to be safe, we want it to be effective, and we want it to be adopted. The actual regulators of AI include the FDA. If you have a medical device that you wish to deploy and it meets the definition of software as a medical device or medical device, you have to go through the FDA approval process in which they determine whether it's safe and effective. And there is a process that I'm sure all of you are aware of. If you deploy an AI through the electronic health record, I get to regulate that. And we can set the standards for how that is developed and how that can make it to market. So if you want your AI to be paid for by the government, that's up to CMS. And the Center for Medicare and Medicaid Services is trying to think through how to actually pay for AI because they recognize the promise behind it. What we've seen is that in order to get AI adopted, it has to be trustworthy, meaning the people who would actually buy it and deploy it and use it with real patients have to trust it. Now, I'm a radiologist by training, and we've been using AI literally for 20 years. And there's about 1,300 AIs that are approved by FDA, and only a small percentage of those are actually adopted and deployed in the market because the providers have to trust it. They have to know that it's actually going to help them and that it won't hurt patients. The second thing is there has to be a return on investment. An AI tool may be a fantastic tool, but if ultimately you have to pay for it and ultimately it costs you money and it doesn't create a significant improvement in care or outcome for the patient, you might not deploy it. And the third thing you need in order to get adoption, in addition to there being an ROI and it being trustworthy, is you have to have data from the patient. Any sort of AI tool has to be customized or grab data from the patient in order for it to be effective for that patient. So that's a little bit about what we do and how we're thinking about this. Mary?
Thank you. Well, nice to be here with all of you. This is a fireside chat without the fire, so that's good for me. At ACL, this is the Administration for Community Living. We focus on older adults and people with disabilities, keeping them engaged, as independent as possible, employed, safe, secure, but living in community and avoiding institutionalization. So we have issued a prize challenge, an AI prize challenge. I'm going to give you the reason why. Caregiving is ACL's #1 priority. What we're known for a lot is the Older Americans Act programs, the largest of which is nutrition. I don't refer to it as a meal. I refer to it as a preventive nutrition intervention, because if you need nutrition, you need more than just a meal. And so that preventive nutrition intervention is how we address that caregiving and caregivers are our #1 priority, because without them, people don't stay and remain in the community. 63 million, you've probably heard this number before, but I'm going to say it again because it's an astounding number. 63 million family unpaid caregivers are the largest sector of the long care system in this country. The long-term care system is primarily made up of 63 million family unpaid caregivers. They're the bedrock. So let's all take a moment seriously and think, what happens to this health system if we don't have those 63 million people? This health system cannot sustain what would happen. We need 600,000 direct care workers, caregivers, paid caregivers, to address the needs that people are looking for right now. 600,000 shy. And when I had that discussion with Secretary Kennedy about a week ago, he knew to say in response to me, you know, that's the #1 job posting in the state of New York, direct care workers, which includes what we call DSPs, direct support personnel, who are people who provide supports specifically for people with disabilities so that they can access community living, access transportation, have personal assistance, support during the day, say at work, and the like. We need 600,000 now, but a few years by 2030, we know we'll need 800,000. So if we don't support caregivers and caregiving, we don't want to have to address what happens without supporting them. So ACL, kind of the start of this was all during COVID. And during COVID, we had so many older adults and people with disabilities not getting access to caregivers, isolated, alone, and we know isolation is certainly leads to malnutrition. People don't eat. They don't have access. people tend to fall. It just becomes a cascade of issues after that. So one thing that was started was technology, not so much AI at the time, but technology tools to keep people connected. And that was actually one of our first prize challenges ever at ACL was getting people connected, reducing social isolation, and COVID was unfortunately the instigator of this. But that has evolved even more into other AI type tools and products. And although you've been using it for 20 years, AI as a tool for the older adult population has been evolving smart homes, wearables, and the like. So this kind of gives you the how did we get into this AI space? We're super excited about this prize challenge. If I can take 1 minute, I'll share with you the prize challenge is to address 2 tracks. Paid caregivers, how do we extend the caregivers that we do have to help cover the 600,000 plus that are needed? How do we stretch what caregivers, paid caregivers and agencies can do? Some are closing because they can't even address the needs. Some are, having to refuse requests for engagement. Particularly for the population, we address those with greatest social need. It's hardest for them to access care and support because agencies basically respond to, if you can, the more you can pay, the more I can provide, because the more I pay a caregiver, the more likely I am to have that caregiver. So highest bidder is getting that service. So we're really trying to address real world issues. We have 81 million older adults right now, projected to grow to 97 million by the year 2040. If we talk about means and ability to support themselves, the median retirement savings for older adults is $200,000 or less. So half of that 81 million has retirement savings of $200,000 or less. So we know these people need supports. So that's one of the catalysts for this. So we're looking at paid caregivers, how do we extend them? And family caregivers, how do we support not only the value of providing loving care, unpaid, to family and good friends, but also how do we support them so they can continue to do that? Thanks.
Thank you so much, Mary. I want to start a round of questions with a theme that I think is probably very in lockstep with a lot of the things that everyone here wants. I think both of you and what you guys talked about, you both focused on this concept of adoption. Like we don't want to develop tools just for tools' sake. You mentioned 1,300 tools. You mentioned, a huge gap that exists in this critical part of the healthcare system. How do we get from research to real world use? So, Mary, I want to start with you. You've now started the challenge. You're seeing all sorts of AI tools come out. People are trying, to fill this gap that you've mentioned exists. What kinds of, AI tools or applications are you most excited about when it comes to caregiving? And what would you say makes particular tools or particular types of AI, ready to actually drive change in for patients or for caregivers?
Yeah, we're really excited about things that, one, overarching for anything is it's secure, it's safe, it provides privacy, but as well dignity. So we talk about cameras, that was something, not so much AI, but cameras. Oh, so we can observe if someone's fallen or the like. But there's no dignity to that. And so those are overarching tenets, shall we say, to any kind of AI application. But beyond that, what excites me, almost all of them in terms of potential, but in particular those that, one, extend caregiving capabilities, either paid or unpaid. So I'm talking about if you can extend caregiver capabilities, then a family that has one individual supporting mom or dad or both, how can you reduce the stress, the burden, et cetera? And I don't mean the burden of providing loving care, but the burden of taking care of their own family, work, life, et cetera, and then the added stress and activity related to family caregiving. Voice activation, communicate, things where families can communicate among each other. Pharmacology, when you can explain to somebody what is the name of this medicine and what does it do, and where do you see contraindications, and where should you see symptoms, and what should you look for, that is most important, where AI can predict things like sensors in the home, smart homes, that excites us. Wearables, where that it can be, communicating vitals and things like that to other family members, where communication can be not only amongst family members and other caregivers. And let me emphasize, why is that so important? Because, the old days in healthcare, we would sit and we'd give a report from one shift to another, and it was often one person's running in and out and answering call lights and everything else, and you're given all this information, and half of it gets lost, and I forgot to tell you on this sticky note, I wrote this about this lady. Sort of voice activate as you're going through the day. Okay, I'm now giving mom her medicine at 2 o'clock. All of this is getting into a tool. Next person, family member comes on. Oh, I'm sorry, I had to take the kids to school and go to this sport, so I couldn't talk to you, but it's there. But it's there when you get there. So that ability to communicate, when it communicates among not only caregivers, but to providers or to a health record, that's like, okay, now we've gotten close to utopia because everybody is getting real-time information. And somebody in all this usually goes, oh, that could be a problem, this might be an issue, and the like. So that excites us a lot. Again, the pharmacology is so important with older adults. Even the questions like, what if I forgot to give mom this medicine? The ability to go and access that education. Many of these people are going home from the hospital and they're caregivers, unpaid family caregivers. Get a pile of paper. It's like, here are your instructions. Okay, so wait, I do this tube feeding. How again? How do I set this? How do I administer it? What do I insert this again to? How is this happening? Tube feedings, wound care, IV, injections. I mean, they don't get to spend a semester putting a syringe in an orange. It's like, okay, this is happening tomorrow. Mom's going home. You have to learn how to do this. So anything that provides the education, I don't necessarily have to go to a YouTube, but it's all there informing me. That excites us tremendously. So the communication, the education, and for the paid folks, that activation of notes and getting the information into a record is great because the QIQs that come back like, what about this, what about this, and what about this, are the prompters.
Awesome. Thanks so much. Tom, I know through your work, you get to interact with huge parts of the health technology landscape, even outside of, this particular application, both EHRs as well as startup companies, large tech companies. So I would pose a very similar question to you, like what, makes tools, AI tools are just generally more ready for deployment than others?
Yeah, the interesting thing is when you're regulating an industry, it's amazing how many people from the industry want to come and talk to you. I had no friends before this appointment, and now all of a sudden everybody wants to tell me about their latest and greatest. We see so many extraordinary pieces of software and devices coming on the market. But I will go back to the points that I made in answer to Arman's first question. The providers and the people who use them have to trust them, and they have to find a return on investment. So the most obvious and most widely deployed AI that we see in electronic health records are the AI scribes. So about 60 to 70% of physicians have adopted these. So I can go into a interview room where I'm interviewing a patient, and Arman is intending to go to med school. He hasn't gone there yet. But if he were my patient, we could simply talk to each other. I could look him in the eye, and I wouldn't have to be taking notes, and I wouldn't have to be typing into a computer. And the AI scribe actually puts into a note all of the information, and it abstracts out important information like billing and coding, what prescriptions need to be written, what follow-up tests need to be ordered, and it tees it up for the doctor. Interestingly, these AI scribes cost a fair amount of money, And they've researched them, and they found that they don't actually save the doctor time. There was a thought that this would maybe save the doctor time, that they would have to do notes in the evening, but in fact it doesn't. And yet it's been widely adopted because physicians like it. It makes their life easier, it allows them to interact with the patient more, it organizes information for them, it decreases their cognitive load. So to the point of ROI, people are willing to pay for it. If it actually, even if it doesn't save them time or necessarily money. Now, there's all kinds of devices that I'm sure you guys are more familiar with than I am in the realm of helping people with aging. One is, have you guys heard of the CrossSense Wispy Assistant? These are glasses that people with Alzheimer's can wear that will prompt them. This is your daughter. This is something you need to do now, and it's a set of smart glasses. There's wearables that can detect when people's gait is changing and can give early detection for when somebody may be developing Parkinson's disease or may be developing gait problems because of musculoskeletal disorders. I wrote down a couple. AI coaches. If you are starting to get cognitive decline, but you aren't at the point where you have to wear glasses, you can use a coach to coach you through your day. And all of these are very exciting and very powerful. And as Mary pointed out, we'd like all of the information captured by these to eventually get back to a physician. And that's something that I focus on, making sure that all of these are interoperable with the electronic health records.
Awesome. We've talked a lot about tools, specific tech things, applications that we're very interested in. But I'm sure everyone in this room, knows, especially for the state of the health, a very fragmented health system that we have, foundational to the success of these tools is data and data flow and interoperability. We obviously have a lot going on at HHS to promote that. So I want to start with you, Tom, given that this is sort of squarely within your office's mandate. You guys have done a lot of work since you came in on growing TEFCA. With that work, what practical benefits do you foresee specifically for caregivers and older adults? And before that, can you give a brief bit of context on what TEFCA is for people who might not be familiar?
Sure. Can I, by show of hands, see how many people here know what TEFCA is? Raise your hand if you know what TEFCA is. Yeah. So TEFCA stands for We Love Acronyms in Government. My actual title is the Assistant Secretary for Technology Policy / National Coordinator for Health IT. And if I bump into any of you after this, I expect you to address me by the full name. TEFCA stands for the Trusted Exchange Framework and Common Agreement. And back in 2016, Congress allocated money and gave us a mandate to stand up a national health information network. It is now 10 years into its existence, and we have exchanged 650 million documents as of today on the network. It allows hospitals to talk to each other. It allows individuals to access their individual medical records. It allows communication between insurance companies and hospitals. All of these functions right now either don't happen or they happen through paid intermediaries. The architecture of the health tech ecosystem is fascinating. There are clearinghouses that do nothing more than connect hospitals and providers to insurance companies so that they can get paid. We're architecting a network that will hopefully provide a low-cost baseline for all of this to happen. So when I was back at Johns Hopkins in 2003, they had how many of you guys are familiar with the Hopkins Access Line? Do you know what that is? Yeah, that's where you can call up Johns Hopkins. You're an outside hospital or provider, typically at about 6 o'clock on a Friday night, and you say, I have a really sick patient that I need to transfer in. And at the time, we used to joke that we would just have to go like this. We wouldn't know anything about the patient, and we couldn't really refuse to accept the patient because we had to take the other provider's word for it. Now, I've been downgraded. I have privileges at the University of Maryland, not at Johns Hopkins, and as of 2026, when I get those same calls on a Friday afternoon, I have the ability to actually look at the patient's medical record in real time, right down to the vitals that are being captured by devices. So when a hospital on the Eastern Shore says, I have a really sick patient, should I transfer them? Not only can I look at the patient's data and say, yeah, this is a patient appropriate for transfer, and we'll give you one of the beds at shock trauma. I can also say he's not appropriate for transfer, but we can pull together a consult group to say this is what you need to do to take care of the patient over the weekend. And that's something that TEFCA empowers, and there's also a local health information exchange called CRISP. And this has really been transformative. After I finished Hopkins, I practiced for 6 years in Zanesville, Ohio. Somehow I got brainwashed into doing rural medicine, which I really enjoyed. And I had a patient who I was giving radiation treatments to for cancer in his liver. And he one day just didn't show up. I would treat him every 4 months, and then he canceled an appointment. And I called him and I said, what happened? And he said, well, you shrunk my tumor so much that I was able to go to the University of Pittsburgh and they actually cut it out. Now, I didn't know that other than by, giving a call to a patient who was, quote, lost to follow-up. And now I would be able to just jump on the electronic health record due to these health information networks and be able to see, oh, this is what happened to Mr. Smith. Oh, wow, look at that. He had his tumor resected. So this is really, it's really been transformational, and that's really my main remit, is getting this data to flow. Not to monopolize the conversation, but there are challenges to that. There are technical challenges to getting data to interoperate. There's concern about people exchanging the data. There are concerns around privacy, security, HIPAA, and so getting all of the actors in a market to actually exchange data is a challenge, and that's at least for why right now I have a job.
Given some of the things that Dr. Keane just mentioned at the end, security, privacy, particularly because caregiving and older adults is you're dealing with a vulnerable population. Mary, I'm curious, how are the initiatives that you're leading at ACL, whether it's the caregiving challenge or other initiatives, how do you guys see your role in addressing the need for security and privacy and information sharing?
Yeah, that's a great question, and we are certainly addressing it, as I said, in the prize challenge. It's kind of upfront tenet that, information is private, it's secure, and as well, what's important is that we're sharing with family and the older adults themselves. This is the kind of information that we're looking to collect. This is how we would propose to use it. You have choices in that, which is, certainly we can or cannot share or use that information. But also the other tenet is relative to the caregivers in their home. The older adult, the family, they own that information. That's their data. So it's not somebody else's data. It's the other point we're making to them is that it's your data. And we've been excited to also begin working with NIA around falls prevention. So that's a big HHS, kind of a full force effort of ACL, HRSA, utilizing FQHCs, CMS through CCSQ, evaluating the intervention, NIA, did I say CDC? Can't even remember who I've said, but 5 different agencies across HHS looking at how do we prevent falls. So just as a quick example, utilizing AI in this, for 15 years, we've been saying the number one reason older adults go to the ER is because of falls. Well, how come we've been saying that for 15 years and we have all these falls prevention programs out there? So we kind of said, well, if we keep doing what we've always done, falls is always going to be the number one reason why people go to the ER, older adults go to the ER. So we have to change something. So we sat down and said, okay, let's make this real world applicable. So I think that's the other thing I'd say to you is when we're talking about AI, you mentioned, Tom, some of these things are really glitzy and nice and sound really cool, but do they save us something? Do they have an impact? If the impact is it's less stress, we'll take that because we've got to support caregivers in terms of their stress and their burden and respite. So on the falls prevention, we're looking at AI to help predict. As you mentioned before, can talk about for people with dementia, can see AI can help to detect pattern changes in conversation and the like. AI can be used to look at gait and over time, what's happening. Are you more likely to fall than somebody else? Then we'd identify you for a falls prevention program. And utilizing AI, we want to see how is that an affordable application that can be used in community-based settings. Because, not to knock Johns Hopkins, of course, but if you have a falls prevention program that's being conducted at a major university, a lot of times, well, there's transportation, so the fact that they come and you get attendance, well, that's kind of counted on. But older adults in the real world need to find transportation, especially if I need to go to a falls prevention program. I may not be getting around too well. So in a real world setting, that's what we're trying to look at, is applying these kinds of things in the real world setting with the tenets secured and overarching. Is this affordable, accessible? Is it set up such that I don't need an OT and a nurse at every falls prevention program, because I can't even get one in every healthcare setting? So those are definitely some of the things we're looking at. We're excited to work with NIA. Other partners come to us because we love the potential.
Awesome. One thing you mentioned, I think that has been a running theme throughout the conversation is, things that actually work, things that can actually be deployed, things that can be adopted, and all the people, the patients, the providers, the caregivers, they all see a real benefit in doing that. We've talked a lot about what is the sort of burden on the person building the tool, right? The developer. But now I want to shift it to what can we do? We're HHS. We're working with these developers through the challenge, through the regulatory work that you do. So Mary, to start with you, through this challenge, you're going to have all these people coming to you with, great tech. Some of it might be bad, but I hope most of it is very, very good.
None of it's going to be bad.
Okay.
None of it's going to be bad.
So what would you see concretely that ACL can implement to make sure or to encourage that adoption? What levers does ACL have? What will you do with these tools, these great technologies, to help them actually make it to patients?
Yeah, thank you, Arman. In this prize challenge in track 1, that's people are putting together their concept, and they'll be judged on concept, given that we've already had one webinar call, and exciting that we had 500 plus people on this call in response to the challenge. We've already received letters of intent. There's a lot of excitement. Actually, Secretary Kennedy announced it on November 18th. We took the time between then and actually in February, when we put out the requirements and so forth of the challenge, is that time was taken to really get with other experts, real world applications, and say what really needs to be designed into this so we're getting the type of ROI that we need. Can we extend caregiver capability? Can we reduce stress? Can we improve the quality of caregiving? And so in that 2-month period of time, we put together criteria such that addresses, like I say, the real world application, but also worked with other experts on how are we going to judge concept. And the lever that we're pulling there is, then the second part of that prize challenge is testing in a real world situation. So they'll be judged on phase 2. For those who advance to phase 2 in this prize challenge, they're going to be judged on real world application. Do we assure security, privacy, safety? Do caregivers feel empowered, less burdened, better communication, quality improvement, knowledge? What are we seeing around families understanding? Is there an advantage to agencies and paid care workers in the documentation burden? How has AI eased all of that? So that's the lever that we feel is best in a prize challenge. And we like a prize challenge because it gives us more flexibility oftentimes than a regular grant funded program does.
Awesome. And Tom, very similar question to you. In some of the work that you've been doing, how do you see ASTPONC's role in contributing to this building trust in AI? And I'd like for, in your answer, if you could also talk about why approaches like mandatory model cards, which is something that I know you dealt with when you first came in, why some of those commonly talked about techniques may or may not be the right answer.
Yes. How many people here are familiar with the AI model cards? Raise your hand. You're familiar with it. So the purpose of model cards, they're like nutrition labels for AI, and the idea is to increase the transparency for how the AI was built. And my predecessor adopted into regulation a requirement that if you deploy any sort of artificial intelligence through an electronic health record, that you have to provide a model card, a nutrition label that specifies 31 source attributes or 31 attributes of that artificial intelligence. So was it a boosted gradient tree? Was it a logistic regression? What was the training data set? Things like that. I was actually at the agency as a career staffer when this was being formulated, and I was not a fan. So I've proposed in a rule that we proposed to actually take these down. And I can tell you why. The first is that this information is readily available. If you are, I've actually purchased AI tools for hospitals where I have worked. I've been on the review committee. If you ask a vendor of an AI product, tell me everything about this AI, including these 31 source attributes, they will provide that. Now, sometimes they'll want to provide it under a non-disclosure agreement because they feel it would compromise intellectual property if it were made public, but they will provide it. And if they don't, you don't buy their tool. And I would hope that when people are deploying these tools that they're very forensic in seeing how they work, knowing what went into them. You don't unleash something on patients until you know that it works. It's a static data set. You know, we specified 31 source attributes that I helped come up with in 2021, and it finally became regulation in 2025. I've already heard from people that we've specified the wrong source attributes, so it might just be better for us to give people guidance on our website about what source attributes to ask for rather than put it in regulation. Another thing is that nobody was using them, so if somebody would just shout out a number, the electronic health record vendors can keep track of how many people actually access these model cards. Does somebody want to shout out a number for the largest EHR vendor, Epic, how many times per month people actually access and look at the model cards? Somebody want to shout out a number? One? Almost, about 50. About 50 times a month people were accessing these. Typically they will get them in the sales pitch initially before they deploy it, and then once it's deployed the doctors don't look at it. Further, you can escape my regulation if you want. If you deploy an AI that's bolted onto the electronic health record, my statutory remit doesn't give me the right to regulate your AI. So all you have to do is put it as an add-on rather than deploy it through the electronic health record. Yeah, there you go. If any of you guys want to deploy and not be regulated, there's your trick. And finally, my concern was that it gave a false sense of assurance to people in the market. You display these source attributes, and suddenly people think there's some sort of government certification that this actually works. Unlike the FDA, we don't have guys with windbreakers and aviators that can go in and actually check that you're telling the truth. This was all self-attestation, and I didn't want the market to believe that that we had given the good housekeeping seal of approval. So that's at least why I proposed to take them down.
Great. I know we're coming up on time here, so before we close, the last topic I want to talk about is metrics. Technology, AI. These are things that are being adopted in care, as well as for this application in caregiving. But it's everyone has a different perspective. It's hard to know. Are we moving in the right direction? If so, and with what nuance? So I'd like to ask both of you. Mary, we'll start with you. Looking 3 to 5 years ahead, what specific indicators do you think that ACL can and will track to see, are we on the right track when it comes to tech adoption for caregivers? And what are the metrics that the people in the audience, myself, Tom, what are the things that we should be paying attention to?
Well, in particular to caregiving, We want to know, one, have we actually been able to extend the work that a number of people were performing, and with fewer numbers, are we still accomplishing the same quality of care? Are we meeting QI indicators relative to care standards? And that's relatively the paid caregiver agencies, those that are regulated basically. Are we able to provide some extension to meet the demand? And we want to learn some of this in response to your question, Arman, during this prize challenge and subsequent ones. Let me go to falls as well, where I talked about falls prevention and where can we use AI in that, which is another priority of ours, is how are we addressing that? So we really want to look at, like I said, we haven't moved the needle. It remains the number one reason. So we're going to want to look in the community settings. So FQHCs are part of these community settings for falls prevention. Area agencies on aging, senior wellness centers. So I'm not talking about lifetime fitness necessarily, where we have a lot of great, opportunity and resources. I'm talking about the at-risk populations who are also the high users of healthcare. Are we making a dent in that? So we're going to use metrics around, these will be a little more on the subjective side, but satisfaction from family caregivers is going to be key to this. Do I feel more empowered as a caregiver? Am I less stressed in doing this? Is the family as a whole happy with AI tools that I'm going to continue to use them? Are they accessible and understandable? Is it safe, secure, and provides for dignity? Those are metrics that we will use going forward to look at what is success, and as well at an actual where we can. So, I could brainstorm, there are so many other priorities. We're going to look at nutrition. How do we use AI in nutrition relative to, I'm often in our preventive nutrition interventions, home delivering that intervention. So just think, I open the door. I'll open the door for these people because I trust them and know them. But that intervention is, I'm looking at you and saying, hello, Mary. Let's see what kind of conversation Mary can have. So if I'm AI equipped in that conversation, I'm recording some of that information that's looking for, it may not be this is Mary's or whatever data, but it's whoever this person is, I'm detecting something in their conversation, or this person can see it or feel it themselves. But you're going in the home and you're observing, am I holding on to furniture as I'm walking around? So in that whole intervention in 5 or 10 minutes, I'm looking at skin integrity, I'm looking at bruises, I'm looking at all of this. Is there odor in the home? Is it unkempt? Is the person unkempt? In all of this intervention, as I go and deliver nutrition and all this other intervention is going on, if I can go from home to home to home and have all of that someplace that I download, it's like I get in the car and I go and I can download that through some kind of AI application. There's a wealth of information there that I can give an ROI to, because I can say on those, what happens immediately, can that go into a health record? Anything that I have just reported as an issue, so that providers and other family members are seeing, and that prevention can save ER, hospitalizations, costs, et cetera. So where we can measure those kind of things, that'll be very helpful to us as well. But we're a lot in development around that.
Great. And Tom, very similar question to you. Given your work on data liquidity as well as just broader, more tech and AI enablement, what are the things that you and ASTP are going to be, what are the KPIs that you guys are going to be tracking?
Yeah, I'll be brief. Are folks here familiar with the access model, the CMMI access model? Raise your hand if you are. Yeah, great. So I think enrollment in the CMMI access model and payments going through the CMMI access model will be a great measure of how successful we are. For those who don't know, the Center for Medicare and Medicaid Services has created a demonstration model in which you can take an app that people have on their phones or that they use at their home. You can enroll it as a Part B provider, as if the app were a doctor, and the app can help patients with cardiometabolic disorders, musculoskeletal disorders, and if you can demonstrate improvement in the individual's functioning or in certain key metrics, you can get a payment from the government, I think somewhere around the neighborhood of $300. And so this is a way to pay for AI. And so enrollment and payment through that program would be a great performance indicator of how we're doing.
Awesome. I think we're right at time. So Tom, Mary, thank you guys so much. Hope you all enjoyed it. And yeah, looking forward to the rest of the summit. Thank you guys.
Thank you.